Okay, so the next session or the next bit is about the caesarean section debate, really. Sorry, just want to make sure. It's about the caesarean section debate, and I thought I would say something specifically about this just to raise some discussion. And I'm going to start with asking a series of questions. And I'm not going to provide the answers because I don't know the answers to all of them. And I'm not sure whether there is an answer. So the first question, can we agree, is a caesarean section just an event? Is it an outcome, which could be good or bad? Is it that word intervention, which I don't think is a very good word because it sounds very negative, and when women are asking for a maternal request, it's almost a good outcome from the woman's point of view in some ways. Or is it indeed a complication? Some people regard it as a complication. The next question is, why has the caesarean section rate increased? And ask yourselves, do we actually know? And I'm not necessarily just talking about why in terms of indication, I'm talking about which group of women as well, and the 10 groups will tell us that. Then the question which is frequently thrown around is, can we reduce the caesarean section rate, or should we even reduce the caesarean section rate? I can give you an answer to that is, yes, we could do. You know, obviously you can reduce the section rate, but the preface is that only when it can be justified, accepted by women, and safely implemented. What is the 10-group classification, and what is the role of the 10-group classification in trying to explain or reduce the section rate? And I'm not saying, and the intention behind the 10 groups was certainly not to reduce caesarean section rate specifically. However, it would be very useful if somebody wanted to do it, but it was more really to explain the caesarean section rate. Personally, if somebody gave me their 10 groups and said, look, Dr. Robson, we want to employ you and we want you to reduce the section rate, and, you know, can you do that? First thing I would do is I would look at the 10 groups, look at the outcomes, and I will make very quick decisions whether it would be possible safely to do it or whether it would be not possible safely to do it. I think we're at this stage that we don't know why we're doing it. We don't know what the other results. And there's people just reacting to try and reduce it. And that can be dangerous. It really can be dangerous. However, on the other hand, the caesarean section rate is going up. What interventions are needed to optimize the caesarean rate? Well, that really depends on where the section rate is high. I mean, the solutions will be different, very different in group 1 if that's high, or group 2, compared to 3 or 4 or 5. I think breaches and twins and other high-risk groups, I think, you know, you would leave those alone. It doesn't really matter because the risk-benefit ratio is very high. Even VBACs, you know, I mean, if you look at 10 groups and populations, the higher VBAC rate you've got, the more uterine ruptures you have. It just is like that because the uterine scar after a caesarean is very unpredictable. And on the one hand, it's really interesting. On one hand, people are using misoprostol to induce. And on the other hand, they're very happy to do caesareans at 39 weeks without any other medical indication, rather than having somewhere in between. What's the ideal section rate? Well, again, you know, words are important. In my view, there is no ideal caesarean section rate. There may be a caesarean section rate that is appropriate in one organization compared to another, but it's never a figure that stays constant, and it's something that you continually have to look at. Some papers have suggested that the caesarean section rate as a statistic is completely obsolete. And I would tend to agree that as an overall rate and on its own, it's always been obsolete and of limited value. But understanding it in a structured manner and relating it to other short and long-term events and outcomes, I think it's now more important than ever for many, many reasons. The caesarean section rate is the fulcrum on which a lot of other events and outcomes, interventions, complications, organizational issues, and maternity care are related to directly or indirectly. And so it's actually really important, not only the numbers, but how they're done, how they're organized, who does them, all of these kind of things. It's very important. So it will be forever with us, I think. I don't think it will be obsolete. There's been a lot written about it, but it's difficult to conclude that any consensus or anything of value has been achieved on the subject. And as professionals, I think we have a duty to completely rethink our position on caesarean section rates. And it starts with really trying to explain what it is, using the 10 groups as a starting point. The biggest criticism we'll face in the future, I think, is not the fact that the caesarean section rate was allowed to increase over our generation, but that we made no effort to study it or its implications scientifically. And I think that's a really important point. And now is the time to act and set up a database so that people, generations to come, never mind the women and babies, but our professional colleagues in the future will be able to analyze information. There's a big debate about a caesarean section having implications for child health in the most general sense. But are they pre-labor sections? Are they after spontaneous labor? Are they after inductions? Could you get to a situation where a woman has been induced for 48 hours and in every way physically and emotionally traumatized, but we don't want to do a section because if we can get it delivered vaginally, you know, it will make the baby a lot better in the future? I mean, let's think about these things. There's some short-term issues that will be in favor of doing a caesarean, and we mustn't, you know, standardize the kind of thought that, you know, any caesarean section. There may be different types of caesarean sections that may have different effects, but unless we set the database up now so we can analyze babies born in the future to come back and see which group they were in, from a public health point of view, I think we're just jumping in the dark. I mean, I don't know, how many of you read those papers in detail? It does suggest that there's some connection, but little more than that. I mean, if you were really strict and if you had a strict analysis of them, I'm not sure they can prove which ones rather than a blanket. And I think we owe it to mothers and babies to look at that, because otherwise we're really, I think, causing a lot of angst in mothers who feel that it was their fault that they didn't deliver vaginally, and later on the baby developed something and it was only because she didn't manage to deliver vaginally. I don't think it's as simple as that. So what I think we should be talking about is validate or understanding a caesarean section rate, and this is the important slide. To validate or understand a caesarean section rate, whichever way you want to put it, at the top you need, well, there's different levels of information, 1 to 4, and level 5 is the processes. So you need to know the 10 groups. You need to know your 10 groups. And within the groups, the subsequent analysis of indications, events, and outcomes must always be within those groups, okay? The next level of classification, or next level of information is level 2 there, indications for caesarean sections. And this is where the gentleman was asking, is he here? The gentleman that was asking about indications, I can't see. This is about indications, and there is no accepted international classification of indications for caesarean sections. It really is quite a mess. More importantly, indications for caesareans are of limited value without the 10 groups. And they're of limited value because the incidence of certain indications vary in the different groups, and more importantly, the solutions vary. The problems with indications are the definitions. We can't agree on the definition. We can't apply them even if we agreed with the definition. And when people do a caesarean section, they often don't put one indication, they just put 4 or 5 indications, just to be sure that it's justified. Now, there's nothing wrong with that, and it may explain in more detail why you did a caesarean section, but it's no good for future analysis. And that's a fundamental data information point. If you don't organize it in such a way, thinking, how am I going to get it out, forget it. There's a tremendous growth in indications. That doesn't help anyone because the definitions become more difficult, there's an overlap, and it's more and more subjective. No indication, very difficult to define. I must say, no medical indication, no indication. I would rather prefer, and I think it's easier from an information point of view, that we put it as it is, and that's maternal request. Because if there's no indication, i.e. the doctor isn't looking to do the cesarean section, it is maternal request. Otherwise, they wouldn't be doing it. Or at least if they are doing it with no medical indication, let's push them to say, you know, that they are deciding that there is no medical indication. And I think for clinicians, you know, we can have a discussion about whether we all agree or disagree on an indication, but where we can't dispute the fact is we have to put something down. You can't just put nothing down, even if it is no indication. And we can take that discussion further. The other problem about indication for cesarean section is retrospective. It is after the event. So if you did an audit of all your indications, as often is in the literature, without using the 10 groups, you've got a whole list of indications. But how do you know which women were dystocic? How do you know which women had a high incidence of fetal distress? How do you know these things unless you have a prospective group? Because the section rates vary so much in different groups, there is a different incidence and therefore a different solution. So I'm suggesting that we need separate classifications for pre-labor, which could either be elective or emergency, or spontaneous induced labor. And if you can take one thing from this meeting, it's a very simple thing, we need to start talking about pre-labor rather than elective when we mean pre-labor. Pre-labor is before labor. Spontaneous induced is after spontaneous induced labor. Pre-labor may be elective or may be emergency, but all sections after spontaneous and induced labor are emergencies. And this is just an illustration from our own section rate, and this is a part, and before we use the 10 groups, is our section rate is 34%. 2/3 of those sections are pre-labor. There's no changes to management of labor that's going to reduce that section rate. Indirectly, there may be an effect, but the section rates in spontaneous and, or due to spontaneous in absolute terms of that overall section rate, you can see spontaneous labor is not the problem either. If anything, it's induction. But that's one of the points, because when you have a high-level classification for cesarean, for pre-labor sections, my view again is that we should try and divide it up into fetal, maternal, and maternal request. And some people will say, well, that's difficult because there's a bit of fetal and a bit of maternal and a bit of maternal request. Well, let's grow up and make a decision. Which one is the main one? Put it up as the main thing. And by all means, put more information vertically within that group. But if we can't decide whether it's mainly for maternal reason, whether it's mainly for fetal reason, or whether it's mainly because of maternal request, we're not going to get any further. And it's pre-labor sections that's going up. So I want to kind of inspire you to think of high-level classification with the main thing which we can all, I say agree, maybe we can't agree, but then we don't agree of when we do things in labor for fetal distress anyway. We all have different margins and different kind of sensitivity on when we would actually do a cesarean section for fetal distress others, or even dystocia. So it's in the eye of the beholder why they're doing it. And I think if we collect that information with subjective, if you want, justification below that, at least you'll be able to search fetal indications mainly, maternal indications mainly, and maternal request. So I'm going to leave pre-labor cesarean sections there, but I'm only just going to say something about maternal request, because again, we don't have a definition for that. Maternal request, I was often asked, why don't you have a separate group for maternal request? Would anybody know what I answered? It's very simple, and I've given the secret away, whatever. Because maternal request, in theory, could take place in any of the 10 groups. In theory. Somebody may go into spontaneous labor, but they don't want to go on because we would want to wait a little bit longer. So it could be within group 1, as much as group 5A or 5B. That's the point. It's information within the 10 groups, not as a separate group. But we do need a definition, and my simple pragmatic definition, and I accept that it will be different, just like the diagnosis of dystocia or fetal distress between clinicians. At the time of the request by the woman, because that's where it comes from, in the opinion of the obstetrician, and we might vary, there's a greater relative risk of a significant adverse outcome to mother or baby by carrying out a cesarean than awaiting spontaneous labor and delivery or inducing labor. But that difference may be so small, even though we believe that, it doesn't mean to say I wouldn't do a cesarean for maternal request, but I would be saying to the woman, under normal circumstances, say a previous scar at 39 weeks, everything else is fine, I would wait a week longer. But there may be reasons that I would justify, at least to myself, ethically and otherwise, that I'll do it, having had a discussion with her, and I will put it down as maternal request. And underneath that, I will say, whatever reason she gave me. And I think that's important. Now, if it's a medical reason, so when we have a woman with a previous scar at 39 weeks, and remember, if this is audited within the 10 groups, we know it's in group 5, if it's a term baby. We don't have to put previous section as an indication if there's no other medical indication. If it gets to 41 weeks and the cervix is favorable, that's a different issue. But at 39 weeks, there should either be a medical indication to deliver at that time. And by the way, I am not one that really goes along with inducing previous cesarean sections. I'd much rather wait as long as possible. I certainly wouldn't use misoprostol or prostaglandin or anything. I may ARM and wait 24 hours, but we can integrate differences in practice. But the point is, at 39 weeks with a previous scar, to call a previous section a medical indication doesn't make sense to me, because in that case, you should be doing it in everyone at 39 weeks. So we have to have an honest debate about this. We have to bring everybody together, those that have a lower threshold one way or the other. I don't think that matters. It's what you felt the reason why you did it. And then encourage people to collect the figures to support that and to justify it one way or the other. And that's a very open definition, but people say, well, it can't be applied. Well, it's absolutely what is applied whenever we do dystocia or anything else. We make a decision, but that is the reason. And I think this slide is very important, and I believe this passionately. Women will always choose the type of delivery that seems safest for them and their babies. I don't know whether anybody disagrees with that as a statement. Now, if a woman chooses a type of delivery that we disagree with, they may be right, and we may be wrong in the circumstances where they're going to have their baby. Or the care that has been provided is not what we think it is. Or appropriate information is not available to make what we feel is the obvious choice. And that may be all to do with not necessarily that a woman wants delivery by cesarean, but she's saying no to the other alternative. It's fundamental about choice. We don't always choose something, remember, because we actually want that thing, but the alternative is something we definitely don't want. Have any of you thought about this? And I think we have to tease that out when we collect information, and we have to look at maternal request within the context of all of those groups. Now, this is where hopefully you'll be interested in this, and we've got 2 publications, hopefully, that will be published shortly. For spontaneous induced labor, there's got to be a different classification. And remember, the reason that you induce somebody is rarely the reason you deliver them by cesarean. Rarely. So if you induce somebody for a preeclampsia, you really, after you induce them, section them because of the preeclampsia. It can occur, but usually it's something to do with labor and delivery. And this thing called dystocia, which is an enigma, And when you talk to people about dystocia, it means so many different things to different people, but it's probably the most common problem in obstetrics and the biggest contributor directly or indirectly to the rising cesarean section rate. Some use it to describe the whole labor, or only a brief period of time in the labor when there wasn't any progress. You treat with oxytocin, for example, and then ends up with a normal delivery. Some use it as an indication or part of a cesarean section, but there are no accepted definitions. And from what you've heard of me today, you probably will understand I don't like things or words that are used that we don't all agree on. What it means, and that becomes a problem if we're going to share and learn from each other. Difficult, abnormal, prolonged labor, failure to progress, failure to advance, labor arrest, macrosomia, obstructed labor. If you look at the literature, you will see as indications for cesarean section all of these in the same table. I mean, I don't know what the difference is between all of them and how it's helpful in terms of having a classification that's useful. I think you come back to the etiology of dystocia, and it's the powers, the inefficient uterine action, dysfunctional labor, incoordinate action, something which I believe is a big issue in nulliparous labor, first-time mothers, and that's where, you know, group 1 and the discussion on group 1 is so controversial in relation to oxytocin. The passenger obviously does make a difference, particularly the way that the position works out and whether there's a malpresentation. And to a certain extent, the size of the pelvis, although that's disproportionately used as an excuse in modern-day obstetrics for CPD and others. And I don't think it's as common as people make out, certainly in first-time mothers. The contentious issues, if we're going to make a classification, is in terms of incorporating the processes in labor, is how you diagnose labor, assessing subsequent progress, when you rupture the membranes, and the incidence and timing and regimen, indeed, of oxytocin used in particular. But if you're going to have a classification, you need an objective classification. The way that oxytocin is used, greater or lesser degree everywhere, it needs to be part of it as an event, whether you used it or not. And ideally, you need a classification, or very importantly, you need a classification that can be used by everyone, irrespective of whether you, of how you manage labor. So whether you use the new WHO labor care guide, or the other end you lose the philosophy that I believe in, active management labor, you should be able to use the classification however you manage. And the 3 questions that help us is the indication for cesarean fetal, but no oxytocin, or is it something we call dystocia? Has cervical dilatation been more or less than 1 centimeter an hour? That's incorporating the dynamics of labor. And was oxytocin used or not? And I don't know how many of you have seen this before, but this is what the publication is going to be about. And it may, we can discuss this at a later stage in the questions, and it may take some time to fully comprehend this, but this is a high-level classification. Think of it like the 10 groups, but there's only 7 groups, and within each of those groups, you need more information. So basically, it is saying, after spontaneous induced labor, the most common 99.9% reasons are you deliver by cesarean section is either fetal, but no oxytocin, or something we call dystocia. As far as dystocia is concerned, there's 2 kinds of labors. There's the ones that go very slowly, and the ones that go quickly, and the old-fashioned secondary arrest gets stuck, either near full dilatation or at full dilatation. And we divide those 2 dynamic labors into inefficient uterine action and efficient uterine action. And the efficiency or inefficiency refers to the cervical dilatation. Okay, now, do we recognize these labors? Woman goes into spontaneous labor. She has poor progress in terms of dilatation. We decide to give oxytocin according to our regimen. We get it up to our maximum dose. There's no problems with the baby. There's no problems with the woman. In the end, we eventually give up. Do we all recognize those? That's classified as poor response. Inefficient uterine poor response. The next example is there's poor progress. According to your guidelines, you treat with oxytocin, or correctly, you try to treat, but because you've got strict overcontracting guideline, you can't increase the oxytocin above a certain level. It stays at that, the baby is safe, but you can't give it anymore, even though there's no fetal distress in this group, but you can't give it because of overcontracting, and in the end, you have to give up. That's dystocia, inefficient uterine action, inability to treat. Overcontracting. The next one is you try and give the oxytocin because of failure to progress, but you can't get it up to your dose in your regimen, maximum dose, because the baby doesn't tolerate it. So you keep it at a safe dose for the baby, you wait, how long you wait is up to, according to your guideline, but eventually you give up and you deliver by cesarean section, and that's dystocia, inefficient uterine action, inability to treat fetal intolerance. Or somebody may go into labor and there's poor progress. And for whatever reason, either a policy within the unit, in say group 1, you don't give oxytocin and you just deliver by cesarean section. Now in our group 1, we have a low cesarean section rate. It is very unusual that we section for dystocia without having given oxytocin. But there are hospitals in the world in group 1 that have a very, very high section rate in group 1, and 90% of them don't get oxytocin, but it is for dystocia. They're the key points that we need to find out from collecting this information and then decide accordingly. You could have a view that the clinical situation in a particular group of women, say a previous scar, you would allow her to go into labor, but if there's no progress, you wouldn't give oxytocin. So there's a clinical reason why in group 5, there may be a lot more of inefficient uterine action, no oxytocin. There may be some areas in the world, and let's get to the reasons that people are so worried about giving oxytocin, it's actually safer to do a cesarean section. Have we thought about that? Or the mother has thought it's safer to do it. So when people talk about the cost of cesarean section versus the cost of vaginal delivery, in order to provide a safe environment, we need appropriate monitoring, we need appropriate analgesia, and if that isn't available, for cost reasons, because we don't have the midwives or the resources to do it, we've got to be honest about that. And then in the other group here, efficient uterine action is either without oxytocin or with oxytocin. There's been no fetal concern at all. Got to full dilatation at greater or equal to 1 centimeter an hour. These are either classified into persistent malposition or CPD. So this is an objective classification with all the variables kept separate, if you like, because all the variables will vary in different organizations. Does that make sense? There's different policies, different things. So what do? You get the 10 groups, you get your indications after spontaneous induced or pre-labor cesareans, you look at your results objectively, there's black and white, that's what they were done for, and then you say to yourself, well, these are our policies and guidelines. That hospital over there has got very much more results that we want. What is the differences? This is what happens day in and day out in professional organizations, whether business and sports. Why are we not able to do this in labor and delivery? That's what I'm trying to question, if you like. So we need the 10 groups. We need the indications according to, as I've just described. We need to know the case mix next. And the main case mix issues, epidemiology, are age, body mass index. There are other medical conditions and case mix and culture and choice, but if they are an important part, let's record that and prove that they are. They probably do play a part, but how much? Certainly age and body mass index, it can be, I think, exaggerated a little bit. But that's something that will come out with the results. The next level of information is looking at all the perinatal events and outcomes, maternal and neonatal, clinical and organizational. And they're important in terms of, how much detail you want to go into. But perinatal morbidity, mortality, HIE, infection, trauma, cord pHs, all the events that happen. It may include oxytocin, it may include all the events that happen in labor, rupturing membranes or otherwise, both physical and psychological audit, emotional satisfaction within labor, and also complications, however you define that. And then there are the organizational issues as well, part of force. So you have the 10 groups, you have the way you have your objective results, you have your complications, and you have your results, and you can analyze the complaints by the 10 groups or subgroups, or the adverse incidents, or the medical legal cases. Does that make sense? And when you have this standard classification, you can look at everything, and then you can begin to validate your cesarean section rate. And this part is not about numbers. This is about level 5, where all the processes that occur, and to a certain extent some of the events and outcomes, but some of them are also collected in level 4 information. So when you rupture membranes, how you diagnose labor, what's your policy induction of labor, oxytocin regimen, vaginal operative delivery, whether you use ventosas, forceps, etc. All of that detailed information. So that, I think, is going to be the future, where you have all of that level information and you can begin to validate a cesarean section rate. So yes, there's an optimal cesarean section rate for every organization, but it's not a particular number, nor will it always remain the same in any one setting, or be the same between different settings. And the optimal cesarean section rate will be how much the organization can demonstrate that they understand it within the population, the implications that it has on their mothers and babies, and the relationship to their processes and protocols. And achieving it, as I've mentioned before, will depend on the professional's ability to standardize their care, the professional's ability to collect and have knowledge of relevant information, and the professional's ability to quickly respond and change as a result of information, and then continuously reassess information. So I'll stop there before I move on and take any questions about that, possibly the classification of indications, or possibly some of the general comments I've made about it. Any comments? The classification, you brought up the classification, didn't you? Oh, he's busy. The classification for indications, do you understand the logic? And do you understand how immediately you can take a classification and then increase the oxytocin regimen, or decrease it, or how you fetal distress, or how you diagnose it? Because they're the fundamentals. And within those groups, you can collect a lot more information, whether it was maternal request, whether it was a maternal medical reason within that, but they still should fall into one of those groups. Some of the examples I give: if a woman has been booked for an elective cesarean section, pre-labor elective cesarean section, for maternal request, and she comes in labor, 3 centimeters, first baby, which group does she go into? Which group does she go into in the 10 groups, and which group does she go into in that classification? 1, 2, no, she's another.
She has a previous section in labor.
No. She's first baby. She's booked for an pre-labor elective cesarean section for maternal request, and it's been agreed. Yeah, so 1. She is in 1, but she's going to labor. A lot of people get very annoyed about that. Well, no, but it's going to affect our group 1 cesarean section rate. But yes, it will affect your cesarean section rate, but she is in group 1. Now, when you took the indication, it was maternal request, obviously, but how do you use the classification that I just described? Which group would you put it into? So she's coming in labor. You have to use that classification. No fetal distress, so it won't be that one, so it's a dystocia one. You could say you're pushing it a little bit, but you have to put it in one group. And the disadvantage, like creating an extra group for maternal request, would be putting again, because maternal requests can occur in any of those groups, in theory, because the CTG could be a little bit, not normal, but she gets very worried, but you would be prepared to wait longer because it's not that abnormal. But anyway, this woman comes in, she's in labor, no fetal distress or whatever, she wants a cesarean section, you go ahead. By convention, we put it into dystocia, even though there's no evidence, but there's no evidence for efficient uterine action. So we say dystocia, inefficient uterine action, and no oxytocin. So there's always somebody that stands up and says, oh God, that's awful, I can't sleep at night if I'm doing that. The point is that it's very rare, or quite rare, that happens. And as long as we know that we consistently put it into one group, when we analyze it, we will know that it's in that group, and we find out the more subjective information, and you'll find maternal requests. Does that make sense? But it's important not to put them into group 2 because they are in labor, and it's important to record how big a problem that is. If it goes into group 2, you'll never realize that a lot of the sections you supposedly did, the whole risk-benefit ratio has changed. Somebody could come in at 7 centimeters, but she absolutely insists that she wants a cesarean section. The benefit ratio is greater. It will still go into that group. Any questions? Any other questions? But when you do collect it, and I'll show you, it is quite powerful how this information is.
When you say agreeable rate for an organization, is it for an institution or a country?
What?
The cesarean section rate?
Is it what? Is it?
For a reasonable rate for an organization? Or
It can be both. Did I use the word reasonable? Sorry, I don't know what I said now, but I said when you actually get this information, it's quite, did I say reasonable? I meant it's very rewarding, very informative to know actually why you do the cesareans. Yeah, great. That's what I meant. Well, it's good to have the information. Sorry, I might have misunderstood. Okay, well, let's move on if there's no other questions. The future use of the 10 groups. We need workshops like this. We need workshops and proper training so people actually have been tested and they go through it and they understand it. We need acceptance and support, and that comes from the users and the women themselves. If a system is no good, nobody will support it or should be expected to support it. The WHO have come quite clearly out, and it's been a big change for the WHO. And in fairness, you've got to be impressed by having made that statement in 1985, and it's really due to Anna Bertrand, who some of you will know within the WHO, and was very instrumental in saying, well, look, we have to look at this again and to look at our results first and foremost, rather than to say a set figure. So that was published in the British Journal. The manual, implementation manual, has been published by the WHO, and there is an update that's soon going to be available. There's the platform now that they have introduced where you can put all your own 10 groups and you can actually get access anonymously to everybody else. I think, I don't know how many deliveries have been put on, but it may up to, somebody else might know, but Anna, I think, said it's gone over 100,000, So people are, there's a momentum coming on. And I know I get, they put the 10 groups on, and if they want interpretation of it, I get an email and I send a very brief interpretation. Usually the message is very similar in most cases, but that's something that's happening. FIGO, again, after the WHO, but in the same way, has come out with support. Same kind of principles, find out the information and make your own decisions. EBCOG, which is the European Board of Gynecology and Obstetricians in Europe, have come out and supported it. And of all of them, this is the most interesting one. This is the Safety and Maternity Services in England. And I came upon this by accident. So this is a parliamentary hearing in Parliament in the UK. This is not from the RCOG. The RCOG, can I add, have never formally endorsed it yet. There's a lot of national professional organizations that have endorsed it. But this is fascinating. And it says here there, It is deeply concerning that maternity units appear to have been penalized for high cesarean rates. We recommend an immediate end to this of total cesarean section percentages as a metric for maternity services. And this is replaced by using the Robson criteria to measure cesarean section rates more intelligently. NHS England Improvement must write to all maternity units to ensure that they're aware of this change. This is the government telling the health executive, bypassing the RCOG, and saying to the hospitals, you have to collect the 10 groups. But they don't even know the first beginning about the 10 groups and the advantages apart from cesarean section. But it's just interesting how things sometimes happen. And this is the biggest support that you've got. So I'm getting kind of emails now, people saying, you know, tell us a little bit more about the 10 groups. So everybody's hearing more and more about this. This was within the last year. But national professional societies and governments have to be quite decisive and clear about this. They all have to understand it, because otherwise it's not fair or appropriate that they endorse something. But it won't reach its full potential until individual countries and governments do fully understand it and what its potential might be. And at the moment, it's not being used anywhere near its full potential. You have a great opportunity, being small island in terms of practitioners, but you know, a big population, to actually put yourselves on the map, because nobody has really taken it to the level which eventually it will go to because of its non-confrontational nature. I'll just go on and finish off, because I think that I'll go on. Oh, thank you. So we'll have time to do the presentations, the local presentation. The 10 groups will be useful in interpreting large observational studies and randomized controlled trials. And it's not me that said this, but when you do a randomized controlled trial, there's going to come a time where people say, well, okay, yeah, you randomized that and these were your results, but give me your background 10 groups, because then I can make an understanding of what environment you were doing that, and is it similar to mine, and will it be the same difference? One of the big problems about randomized controlled trials, maybe half the women asked don't actually agree, but by doing this you'll get the background prevalence. And this concept of intention to treat is going to become important. So it's something well known in randomized controlled trials. You divide it into 2 groups and you just look at the result. But for this to succeed in observational data, you need prospectively identifiable groups of women. So my imagination goes a little bit in different directions to others. But is it possible to identify a group, both clinically and economically, if you like group 1 or group 1 and 2 together as a cohort, and base it on an intention to treat? So you have this group, you've got the problems of, if you like, stillbirth rate and adverse incidence or whatever. You treat in a certain way according to your list of processes and protocols, and you see what your results are. It's not actually a randomized controlled trial, but with big data collection, it's going to be as close, and it's going to be as economic, and it's going to be as useful, maybe even more useful, I would argue, than a randomized controlled trial, because you'll be testing your outcomes, your results, your economics, your one-to-one care, all of those against your processes and protocols. And the intention to treat the cohort of the patient may be a hospital population, a group practice, an individual's practice, private or otherwise, or a specifically predefined group of women. You can look at all the insulin-dependent diabetics and do the 10 groups. You can take all the women over 30 and do the 10 groups. It's prospective information. You can identify it beforehand. You can look at, there's a paper from Canada that looked at all the women with different levels of infertility treatment and done the 10 groups on them. Once it becomes a recognized key way of looking at things, people will remember what the normal sizes are in their own populations and outcomes according to it. And you can do any combination of those populations. The 10 groups will not only inform your results, but it will actually inform you on the makeup of your original population. So it is merely beginning and not an end in itself, and it's an initial overview. And most importantly, I remind you again, it's a classification. It's not just a classification of cesareans, but a classification perinatally of all events and outcomes. And quickly here, I'm just going to, because we are running out of time, I want to have enough time to go, is once you have the 10 groups, that's the starting point, you look at group 1 and 2 together. You add them together. You look at the sizes of group 1, 2A and 2B as a proportion of that cohort of single cephalic nullabs. And if you want to look at the section rate, you look at the section rate in total over 1 and 2, and then you look at it in 1, 2A and 2B separately. And these are just some of the tables that are taken from our report. So in 2022, 53% induction rate in single cephalic nullabs. Quite extraordinary, isn't it? I'm not master anymore, I'm not the boss. You're only boss for 7 years, but I'm more interested in data collection. There's quite 7% are pre-labor sections, and 39% only go into spontaneous labor. And if you look at the contributions to that absolute section rate of 32% in groups 1 and 2 together, you can see spontaneous labor contributes very little, mainly because the size has gone down, but also because we've got a low section rate. But pre-labor section, we're doing more, but it's an induced group that it's gone up, that big contribution. Now, is that because we shouldn't be inducing? Is it because they should be induced? And the reasons why they're being sectioned is for fetal reasons, and we're doing the right thing. It's just showing drastic changes, you know, in our perinatal outcome, and therefore it is the right thing to do. Or is it the way we induce? People induce in different ways. Our inductions go on for a day or so. In many countries, they have a much lower section rate in induced women, single cephalic nullabs, but it goes on for 4 days or 5 days. Where does the balance come with what women want, what is best medically? And interestingly, they may have a very much lower cesarean section rate. I'm not going to mention any particular countries, but they may have a lot lower section rate. But the longer a labor goes on, guess what? The PPH rates go up quite significantly in terms of delivery. And that's not because of cesarean sections, it's because the inductions which have led to cesareans. This is the kind of information that we expect, and you should be expecting. So this is group 1. So we've got the ARM rate. Prostaglandin obviously is 0 because they're spontaneous labor. The oxytocin rate, the epidural rate, and these are over the different years. Fetal blood sampling, vaginal upward delivery, APGARs less than 7 at 5 minutes, cord pH, all in the individual groups, not overall. Episiotomy, cesarean section at fully, admitted to the neonatal unit, OASIS, length of labor more than 12 hours, age over 35, BMI, PPH rate, HIA. Do you understand where we're going? Or where we need to go? But it is a challenge. And using this classification, which I talked about, we can classify the reasons for cesarean section in group 1. So you can see fetal reason, no oxytocin. So we've got a low overall section rate in group 1 if you compare to other hospitals. It's gone up a little bit. It was 7 or 8%. But these are different reasons. So we've got fetal reason, no oxytocin is 3.8. Inability to treat fetal intolerance, 3.9. Inability to treat overcontracting is very small. Poor response, but a very low indication for malposition or pelvic disproportion. And our philosophy in group 1, and I think that's where other ways of managing miss out, is that we believe that inefficient uterine action in the first-time mother is the biggest issue. And we make sure that we treat that appropriately. So we have a higher rate of fetal intolerance inability to treat, but that's only because we've got a higher protocol. It doesn't mean to say we're causing more fetal distress, so we get to the top level. Now, when you do that like we've been done for 18 years, look at that data in terms of the classification. So the blue one is fetal no oxytocin. The orange one is dystocia, inability to treat, fetal intolerance. Then the next one is overcontracting, poor response, dystocia, no oxytocin, and POP. So this is 2005 to 2022. And one of the great things about a classification is its consistency. That is so consistent. Now, if you had another hospital that used that classification, which is very simple, and they have different policies and guidelines, it'd be interesting to see. And some countries I know have very, very much less oxytocin, much dystocia, no oxytocin used. Okay, so that's group 1. Apply it to group 2. completely different. So these are all the indications for inductions. And if you've got the indications for inductions, fetal or otherwise, and put this on top, then you get even more separation. So so ruptured membranes, spontaneous ruptured membranes that are induced, have far more poor responses. And fetal reasons for indications have far more inability to treat fetal. It's just very obvious, but here is proving it. This is group 3. This is the section rate in group 3. The section rate is so small in group 3, all the indications are irrelevant. Multips look after themselves, at least in our population. 4A, induced multips with no scars, you can see it's somewhere between group 1 and group 3, if you like. So it's not as high. But in induction of multips, the section rate is about 6-7%, so consistently. And then when you look at previous scars, this is spontaneous labor, you can see the section rate. I don't know whether you can see the figures, but that's about 20%. Very consistent if they go into labor themselves. And you can see there's a lot here of dystocia, inefficient uterine action, no oxytocin. So we try and encourage women to go into labor, but we don't try very hard once they go into labor. Does that make sense? And these are the things that need to be looked at. And this is, for the few people that we induce, I don't induce many previous scares, if any at all, and I certainly wouldn't use drugs. There it's so haphazard, you can see. But again, there's a lot of dystocia, no oxytocin. And this is when you look at all of those groups together. And that's what we're hoping to get published, and in simple terms, encourage other units to use that classification. And these are the key events if you really wanted to start anywhere: the oxytocin rate, the PPH rate greater or equal to 1,000, OASIS, vaginal upper delivery rate, cesarean section rate, the incidence of cesarean section at full dilatation, the cesarean section indication according to this, APGAR's cord pH is not really necessary. The cord pH of the OASIS may not be absolutely necessary, but if you knew those about your labor, you'll know a lot. I want to just talk about induction of labor. And again, like indications, again, we have a system, a high-level system for looking at indications. All indications for inductions, and this is using 1 and 2 as the denominator, because all of them could be induced. We have fetal, we have SRM, not in labor, we have maternal, we have PET hypertension, we have post-dates greater than 40, less than 42, we have post-term greater than 42 weeks, not recorded. We do put bad information in our report. This is from our clinical report. So if it's not recorded, we stand up and say it's not recorded. Now we can correct it, but it's trying to make a point in the report. And no medical indication or maternal request. But again, you can talk about, for example, maternal. That does not include diabetes or age. That's put down as a fetal thing. But if you have these high-level classifications of common reasons for induction, fetal covers a huge range of fetal indications. But surely it's better to put it under fetal first and then divide it up into whatever you want, bleeding, oligohydramnios, small baby, or whatever. Just knowing how many we interrupt a pregnancy for fetal as opposed to any other reasons. And that will give a lot more information than the unit that collects 100 indications and can't make sense of it at all. This is just showing how the 10 groups are used. This is from Brazil, and comparing our unit with Brazil. Brazil is here. This is their 10 groups. We've got 23,000 women here, and we've got 7,000 in ours. It's looking at PPH rates, greater or equal to 1,000. The cesarean section, can you see, is 87% in this hospital in Brazil, and it's 31% for the time we looked at in our hospital, okay? Now, look at these yellow and red columns. There's the overall PPH rate, 3.7 in Brazil, 4.0 in the National Maternity Hospital. Look at the transfusion rate, 1.5% and 1.3% in our institution, okay? So they're very level, very equal, but there's not as much difference. So this point about cesarean sections associated with bleeding, and one of the reasons we give about one of the risks, it's not as simple as it's made out. And the practice in Brazil, if you look at groups 1 and 2, is where it really stands out. So 1 and 2 as a cohort, an intention to treat, comparing single cephalic nullips at term in Brazil, in this hospital in Brazil with us. And you look at here, their cesarean section rate is 85%, and in ours it was 27%. Their PPH rate was 3.5%, ours was 5.4%. Transfusion rate was 1.1%, and our transfusion rate was 2%. Fine, okay, you could say it's the way you measure or whatever, but both hospitals try and measure as in a similar way. Okay, what's the reason? One has got 3 times the section rate. The reasons is, in group 1 and 2, there's a different policy. They are far more likely to do pre-labor cesarean sections. We induce and have longer labors. So looking at it that way, as opposed to looking at the section rates backwards, the intention to treat, they've got lower, or at least lower statistically, or at least the same. This is one of the ways that the 10 groups can be used, because it's an intention to treat. Now, I'm not saying it's justified, because what they lose is by the section rate and the implications of that. What I'm trying to show you is how the 10 groups can be used. Sorry, I'm nearly at the end now. This is something really important. It's an irony to me that in low and middle income countries, there is no electronic tool at all to carry out structured perinatal audit. And I've tried to, with a computer programmer, offer an electronic tool free on the internet, which I'm happy to demonstrate sometime in the next 2 days, to enable people, if they're willing to use it, and it's free, it's only a question of where the data is stored, and it will give you amazing detail, immediate detail about your outcomes. Interestingly, high-income countries have the same problem, but for a different reason. They've got very sophisticated electronic records, but they're so sophisticated, in my view, so poorly written, they have the same problem. They can't get the information out. And although this tool was written for low-income countries who don't have anything, and it may be easier for them to implement it, the high-income countries are looking at it the other way. They're going to push relevant data into this system and make it easier for them to analyze. And I'm just going to show you very clearly. This is the slide you want to record, or we'll make a note of this link if you like, but I can send it to you. You've got my email, you send it to you. You can do the link, you can register, and you can log in, and you can actually pretend to put a few labors in, or a few deliveries in. You can see where you go from there. And if you are interested in your unit doing it, let me know. This is what you've got. It's a shame it doesn't show up here. There's no way you can make that clearer, unfortunately. Basically, there's a very antenatal, entry. You can't see it at all, actually, can you, really? It can't be made clearer in any way, can it? I mean, it's so fuzzy. Anyway, that's the whole data sheet that you collect. It's very simple, nullips and multips. It's designed on the 10 groups. Everything will be analyzed according to 10 groups. These are all the events and outcomes in labor, and this is the result in terms of section, indication, according to how I've described. And it's got a very unique facility in that any postnatal events can be recorded retrospectively afterwards. So if the mother needs a hysterectomy on day 1, you can go back and put it in. Now, it's very simple. It doesn't go to the nth. I don't know what happened there. Zoom. Yeah, don't. Zoom is going to confuse it. But it gives very good reports, and I'll show you what. But it also gives you a partogram, too, in a very simple way, which I still think is useful. The partograms that are being popularized at the moment are far too complicated for me, and I can't understand how to use them. This is very simple partogram. It's taken all the important information like hours and cervical dilatation, any events that occur. Anyway, you can get the information. You could do a report according to the different dates. And when you do the report, you can manipulate the report by saying, what was the planned care pathway? Was it out in the periphery? Was it in hospital? You can look at the age, a BMI. It's a shame you can't see any of this here. But you can manipulate how you want to look at the 10 groups. You press a button and it returns. You can even put all of those that had oxytocin, do the 10 groups on. All of those that had different BMIs or age, and do the 10 groups. You end up getting the overview first, and this is just the nulleps, multips, previous scar. This is the pathway to delivery. This is the type of delivery. This is the category of the pregnancy, and the completed weeks of gestation. But then it gives you the 10 groups with all your results. And do you see this plus sign? You can't see it. There's a plus sign here and there's dots here. You press the plus sign. This is what happens. It gives you, you remember that list of the ARM, oxytocin, that comes up just like that. 1 second, one press. But also, you can, if you've chosen the plus sign, it will give you a list and a table. If you press this, it will give you the number of women in that group. So you could have analyzed it for those that had oxytocin or those that had a cesarean. But it will give you the number of women in that group, and they will come up with their hospital numbers, and you press that, and that's what you get, that delivery. Do you really understand that? Do you understand how simple it is? And those labels to put in take 5 minutes to put in. They're just a key kind of the previous history, the age, the nullip, multip, whether it's spontaneous, induced, or pre-labor section. These are all the events: rupture membranes, oxytocin, and labor. And these are the results here. And there's a free text here to add anything that isn't collected. It won't give you anything. And even if you had your chart system, if you filled in this as well, you can search quickly for all women had oxytocin to induce at 45 years old or whatever, and get those numbers out, and then you can get the chart out because you've got the hospital number there. And you can get all the detail you want from the original chart. This is high-level scrutiny of care at a very basic level. And that's what we're going to get. So this is the last slide. The biggest advance in 21st century perinatal care to the mother and baby is going to be as a result of better routine structured data collection, more sophisticated analysis, and improved implementation of appropriate changes, which may be different depending on the circumstances. So this is not to try and tell you how to do things. This is to allow us to learn from each other and have the debate. But the opportunity is there, and government and people have got to decide whether they continue with their information system, or at least maybe 1 or 2 units try that, and even use it to see what can be available or what the way you should be thinking. So that's it, I'm finished. But are we going to look at some data now? Local data? Is anybody? Yeah. Do you want to? Yeah. Have you got your slide? If you give the slide and you present it, and if you let me, I'll comment on it. Has anybody else got it? You got some? You've been very quiet. What?
We had yesterday discussed. I don't think we have again today.
You don't want to present it? Oh, the data we presented yesterday? Okay, it's up to you whether you want to present it, or let's present this one first. Is there anybody else? Have you got some? He's got some. Go on. We saw the data yesterday. You go. Are you worried? No. Good. After this, yeah, okay, we'll do it. How are we doing for time? We're 12:15, so we've got a little bit.
Right, so I would present, there's something here. Okay, right. So, sorry, so we analyzed these deliveries in Disoesa Hospital for Women. That's a tertiary care center in Colombo, which we get most of the referrals from all around the country. And this was done in 2019 with a web app that we developed. I would just go for an introduction. It's something just similar to what you have done, but might be a little bit different, so you can tell me about that as well. Yeah. And the data was collected and entered by research assistants, and ethical approvals observed. And what we did was, there was the same study done, same way, in 2017 in the same unit by Professor Saranayaka, and we tried to see what was the trend was. So because we wanted to test the app whether it can get the trend. So about the Robinson's trend loop, I won't lose time on these things. So this is the app that we used. Still again, it's not very clear, but it's basically the same way. We entered the main 6 variables that we had to enter, and after we saved, we entered the indications as well, which are commonly used in our units. So it is up to alterations, it can be altered, but these are the common indications that we used in our units for emergency cesarean section and elective cesarean section. What the app will do is, it will give us the absolute, it is based on the WHO guidance. So it will give you the group rate, the group number, the rate, the absolute risk, absolute cesarean section rate and the relative cesarean section rate, and it will give you, it will compare your, automatically it will give you why our rate is different from the multi-country survey and the recommendations, and what might be the cause, and what are the changes that we might have to do to alter it or to come to an agreement. So that's how the app worked. So this is the raw data sheet that we get. It is a cloud-based system actually. So what is the important point? So here, these are the data that we have got of this 1,700 odd for the months that we did. So this is the rates that we have got, so and the relative contribution to overall cesarean section rate, and the group size and the group cesarean section rate is there. So you can see group 1 we had 17.5, and group 2A, which is induced, which is very high rate for that matter, 32.1% had cesarean section. So we were looking at that, and we had a very high cesarean section rate in group 5A as well, that is past sections. So we are not doing very good in past sections. This is the last categories, but I would like to go with these slides to see type of population in comparison to Robson's guidance and other studies. So size of group 1 and 2. So the Robson guidance says about in the WHO manual 35 to 42, and in multi-country survey it was 38.1. In 2017 it was 38.1, our one was 40.5. Robson's group 3 and 4, it usually represent about 30%, so we have had a higher percentage than this. And then group 6 and 7, that is breaches, should be 3 to 4. You can see we had a increasing trend of breaches coming in from 2017 to 2019. And then other interesting point is Robson's group 10, that is preterm. You can see normally it's less than 5, and even in the multi-country surveys less than 5, but our population is high risk, so that's why we are getting 7.8, and it's even increasing now. So that means we are getting more preterm referrals into our center, and that might be a case where we are having a very high cesarean section rate. So ratios of group 1 and versus group 2, the ratio should be 2 or higher. So yes, in our one it is 2.1, and 3 versus 4 again we have 3.1. So these are markers to see whether our group population is comparable to Robson's. And the indications we have, again, analyzed these indications. I think our problems were spontaneous, the failure to progress in induced labor, which was a big problem, which is 15.7%, and then CTG abnormalities, which is 32%. So, a huge problem that we are deciding on cesarean sections because we are not sure about the baby, whether the baby is doing well. The other thing is actually we had high number of preeclamptic toxemias getting seizures, so 14.2. Others are basically negligible. I think you talked about this, the quality of data, how you analyze that, so I am not going to go into much detail about that. But this slide is important. This tells about the trend with over time, because we wanted to see whether we can check the trend over time. So, what is happening to different groups with over time. So, group 1 actually has been stable, but rather than group 1 where there is a little reduction, all the other categories have increased. So, we have increased rates in group 2, 3, 4, like I mean all the categories actually have increased. So, there is an alarming point there. We are, the trend is increasing, we have to now sit down and look into what is happening, because it might go even further in the future. So, that was an interesting finding that we did. So, that's the same slide again in a bar chart, where you can see that everything is increased over time, group 1, group other than group 1 actually. Group 1 has reduced a little bit, but other groups, the cesarean section rate has increased. Yes, so that's what we tried.
Can I have a look at that? If I can just go back. Any comments from the audience? Thank you for doing it. Where's the first slide? Oops. Any comments in relation to what I was presenting? So that's fine. That's good. Okay. So you collect the groups, all right. Do you get all the events and cesarean section indications within the groups?
Yes.
You presented it separately, though.
Within the group.
Oh, yes, within the group.
Yes. We can get within the group as well.
Okay, fine, okay.
Yeah,
I didn't know whether you could on the app or whatever. But the important thing is, and this is the raw data, this is my first comment. What's my comment on this? It's no criticism, it's just a comment. What do you think I'm going to say? Sorry? Come on. No, he's only shown half the table. You need the whole table to have a view. It's so important. Now, I sent some slides. Where's Sarantha? I sent some slides, and I said, use those slides. Did I? Or did you get that message?
Yeah.
We can't even agree on the table or how we show the table. It is crucial to get all the information recorded on one slide and then do it afterwards. And the reason why we couldn't get it on the slide was because...
It went to the underneath one.
Yeah, I know, but
Yeah.
it's because 2A and 2B, we wasted a space there. That should be 2. 4A and 4B and 5, and you get it on. Honestly, the more information, the more understanding, because I'll be able to check one group against the other. It is not uncommon that one group size-wise is bigger when it shouldn't be, and there's a group that you can immediately go and look at. So I would advise using that table, and everybody will get used to the table. The other thing is that when you look at this, I have to add these together because of that ratio. And it's interesting to me that you have got a 2-to-1 ratio. So I would be interested, you say you're a tertiary referral unit, I would have expected the ratio to be a bit flatter or a little bit the other way. Do you understand what I mean?
Yeah.
So that's an interesting thing. You have shown consistency, and that ratio is always less than this ratio, okay. And you've also shown the size of 5A and 5B, 11.1. What's the overall section rate? I can't.
That's the cesarean section. Overall rate was about.
Yeah, where is it there?
That's the cesarean section in that group.
Yeah, but where's the section rate overall?
Total is 33%.
Okay, so we didn't know that. I'm being hard on you. You're very, do you see what I mean? It's about having everything, and then you can add up the absolute values. I don't use these. I think it takes the eye. It's not. You can work out the relative rates from the absolute rates, but the absolute rates. So more is less, less is more. That's an extra column that we don't need. I would put that in one column, so you get the numerator over the denominator in one column, and then put it all on one slide. I think you're right about the breaches. You've obviously got a very high preterm delivery rate, and I would suggest, where's the section rate in that? 52% section rate in group 10. That suggests that that preterm delivery rate is more due to a tertiary referral unit and then not in labour. Does that make sense? If preterm spontaneous labour was the reason for your preterm delivery rate, you'd have a lot lower section rate. Does that make sense?
Yes.
So this is a tertiary referral unit by the size of this and the type of sections in this. If it was spontaneous labour, we've got problems stopping it. It shows quality information. That's 100%, 0.3% there. And the breaches are, so even you've got one breach on one slide and one breach on the other slide. Do you see what I mean? So the purpose of sending so whenever I go to these, I send, these are the slides. This is the one table that you use. But you're not the first one. Everybody does the same thing. They redesign their own slides. And I think it becomes a problem when you're trying to kind of show information quickly. But the breaches, just where it's 2.3 or whatever, that shows that ratio again. And to tell you the truth, the one thing that stands out to me in terms of section rates are, does anybody know what I'll say, which groups?
Induced.
No, I'm not interested in those. I say that you're telling me it's a tertiary referral unit. I know it is. They're probably, the smaller induced group, if you really only induce the most difficult ones, you're going to have a higher section rate in those. So I don't think that is, and I don't think it is. I think that's relatively reasonable section rate there. No, the section rates that stand out to me are this and this. Yes, this is high, but this is high relative to that. So in your group 3, have you got a population where you've got multips having more than 6 or 7 deliveries? Is that rare?
6 or 7 is rare.
Yeah. So 3 or 4?
Yeah.
That's quite common, okay. Because that is really high, in my view. I'd be interested to know what it is. And I don't know whether you've got some of your previous scars, because this size is a little bit smaller than I thought it would be. So 5A and 5B, half the total section rate. Your section rate is 30%. I expect it a bit higher. The most common reason why that is high is inadvertently you've got women with previous scars in there. And you look at that section rate in group 4A, is that 4A?
Yes.
17.4% of women that are induced with no previous scar. That's quite high. Ours is about 4 to 6%. Add on a few more percent. So I would investigate that. I wouldn't worry about that. That is very good. 25 to 30%. You go on for 2 days, 4 days? How long do you have your inductions for? How persistent are you?
Maybe 1 cycle, 2 cycles,
Yeah, exactly
maximum.
Like us. Yeah. I bet you've got a pretty low PPH rate as well. I wouldn't worry about that. That's good in 5. There's units that have 20%, but they go on for days and days and days. This is high though.
That might be due to, high-risk multips coming in.
Okay, high-risk multips coming in, fine. But why don't you just section them then? I mean, if they are favourable to be induced as a multip, multips usually respond. I mean, okay, there may be a high risk, so they're sectioned for fetal reasons or dystocic reasons.
Most probably fetal reasons. But if there's PIH, all these things, we might not be
SPIH. What?
preeclamptic toxemia and all these things, got referrals, we might not be pushing them too hard.
Okay. But in multips, if they're very unfavourable, would you induce a multip and see how she goes, or would you section her?
We'd still induce, I think, that's the case.
Right, okay. you have got very few pre-labour sections in multiple. So you may be right, you try and give it a go or whatever. But it'll be interesting to know what the reason for that is. All those
That is the cause, I think, what I thought. I mean, we induce them at the cost.
I mean, you could say that, you see, that's what's interesting, is that you've got very few, it's 100%, but you've got very few, small group of...
No, we don't, we don't call
So you
section.
give everyone a go. I still would, no, maybe that, yeah. Okay, any other comments yourself? Can you go to 8, the next one? Yeah, so the group size is 1.9, 72%. All these section rates, they're kind of irrelevant, I think. 0.3%, so it's good data quality generally, the indication. And then if you go into the indications, yeah. Can I just say, what am I going to say here about failure to progress? So ideally they should be per group. Would you be able to do it for group 1?
We have to get it.
Would you send it to me?
Yeah.
Yeah, okay. What's one of the things that's missing here? And what is it missing from this, and it's missing from that? I don't know what labour emergency is. What's that?
That, I'm not also sure.
I don't know what's it measured. What, do you understand that it's difficult to make sense of it, but there's two things
Maybe.
missing. What?
Maybe like
I heard it whispered there, right?
cord prolapse and that.
Sorry?
Cord prolapse, maybe, I mean, an emergency.
But you see, the CTG abnormalities, meconium, they're all fetal reasons, whatever they are. Wouldn't it be simpler to have them under fetal and you get a high level? There's no mention of oxytocin here. So I don't know where the fetal conditions, whether it's true fetal distress with no oxytocin, which I think you will agree with me is very different etiologically to dystocia, which is treated with oxytocin and then the baby reacts. Would you agree? You stop oxytocin so baby comes in, and for whatever reason you section, but unless you collect oxytocin, you don't know what was. Does that make sense?
Yeah.
So in the classification I presented, it will differentiate between those.
This induced labor
Yeah.
is, we normally, once you do ARM, we'll start syntocinon.
Okay, but I still don't know whether that's the ones that had the section.
Yeah, that's the percentage of failure
Yeah,
progress.
but
in
you
this
use
level.
propest, don't you, or prostaglandins?
Yeah. No,
So
you mean whether it's prostaglandins without syntocinon?
Yeah.
Yeah.
Oxytocin is so key. With the classification that I'm suggesting after that, you'll get a lot more information about it. But look, it's great. And if you could get the indications separate, that would be really good. So for fetal reason, you need to know whether it's before oxytocin or as a result of it. And if it's induced and you've got the indications for induction, you'll actually know how many you induce with prostaglandin for a fetal reason. You section for fetal with no oxytocin.
The indications need to be developed more because.
Do you think you could try to use the ones? Are you interested? Or
I can try that one as well because this initial Robsons we just tried with the basic data, but we included this as well to get some more information. But I think it has so much to evolve. I think your one. It has evolved so much, you have thought about it a lot. But I have not thought about that much.
No, but it's trying to get the beginning point. But if you do that and have a look at the link, especially because your experience with your app, you know, it would be very interesting for you to see how much more you can get out. Because I'd be interested from the app that you can get some information out. I don't know whether you can get it per oxytocin, but can you get the individual labors out to look at them?
Anything individually we can get, and the rates can be get.
No.
That's feed.
It's just anonymous into the thing.
Whatever we have not included cannot be getting. I mean, so what you were telling about the indications we have not included. So
Okay. Any other comments, anyone? Oh, well done. That's brilliant. Thanks for presenting it. Okay. We've got 5-10 minutes left. What's your first name again?
Chandan.
Chandan. It's Dutch.
Sorry, actually, when we were preparing this, actually, I didn't have this much of knowledge about this thing. This was done in last year. So the main objective was to audit this according to the classification. And the other objective is to actually to audit the indication for cesarean and to compare the rates among diabetic mothers, and also compare the induction rate. So I'll skip this part. And this is the demographic classification. We have included 241 patients within 3 months, and most were primaries. That is actually 52.3, and almost majority 96% were term deliveries, and 37 women, that is 15.4%, had a history of past cesarean section, and out of that 150 were vaginal deliveries, and cesarean section rate was 37.8. This is the normal deliveries, and we put like emergency and elective cesareans. Now this is the bar chart according to the classification. You can see the 2A group, the percentage was about 46.8, and group 3 it was 4%. The cesarean section rate. And if I go to the table, actually I didn't calculate the overall percentage according to the overall cesarean section rate. The high incidence we found in the nulliparous who had induction and the previous cesarean section group. So.
Okay. Shall I
Yeah.
interpret? So, yeah, we haven't got the absolute rates to get the absolute contribution, and you need to work that out. But let's look at the sizes. So, yes, 51%, that makes sense, because it's 48 for the cohort of 1 and 2. And if that's the case, sorry, I'll come over here, 48%, you add on a few more percent, so it's 51%. That is more nullips than in a average population. I hate using that term. But anyway, you can see the ratio is much flatter. It's nearly 1 to 1. And that suggests that, you know, for whatever reason, inductions are being carried out more commonly than maybe in other places. And that may be changed, you know, it's 2022, so that's probably changed like ours over the years. The next question that this brings up, I'd love to know what the stillbirth rate is, and obviously I'd like to know what the indications for inductions. That will be the natural progression, if you like. Again, note that this ratio is 2 to 1, and there it's 1 to 1. This ratio is always greater in multips than nullips. It's a validation of good quality data. The size of group 5, 13, 14%, is a little bit smaller than you would expect. It would be a little bit higher, about half the rate. So you're always looking out for groups 3 and 4 to see whether they've got high section rates because there could be some previous scars missing, if you like. But that may vary for different reasons and how many babies women actually have. But the section rate in 1 and 3 are very, you know, they're very, you know, reasonable, providing the baby outcome is good as well. Those section rates would be low, and therefore don't contribute that much to the overall cesarean section rate apart from the actual size. This is the group that contributes most. The section rate in group 4, 48% is very high. And that, in my view, would be because of pre-labor cesarean sections. So the section rate from the previous speaker showed that it was 17%, which I would said high in 4A. Here, 4A and 4B is amalgamated. But if you take the numbers that were induced and say they were 6% section rate, maybe add on a little bit more, 10%, it wouldn't bring anywhere near the 48% cesarean. So I think
That
There are
is
a
the
lot of
one which is-
cesareans done before labour in this institution. The most common reason why a multip has a cesarean section before labour is, what do people think?
Maternal request.
Sorry? Maternal request, because of a poor, bad experience. Or, remember what we said,
Induction.
Group 5 is a little bit low, okay? There could be some women inadvertently in Group 4 who've got a previous scar. That would be a common reason to have a cesarean. And sometimes, and I'm not saying it happened in a hospital in Australia, that when they come in for a pre-labour section and it's all organised or whatever, the data collection may sometimes be a little less meticulous. I will bet you don't think so. I think, no, I would guess there's some previous scars wrongly in there. Do you think that's a possibility? No? Sorry?
I don't think. No, I don't think.
Do you understand where I'm coming from, though? That's really high, that section rate there. The only two reasons are maternal request because of a poor previous experience, or inadvertently there's some previous sections that have been inadvertently classified there. And the reason I say
Or
that...
maybe the induction.
Sorry?
Maybe the wrong induction.
Induction of a multip, unless they've got 6-7 deliveries when maybe they shouldn't be induced anyway, they have a lower section rate. They do a lot better. So, okay, you could say it's induction. I would be surprised. That's all I can say. I think if you are inducing a multip, they should do better than that. What does everyone else think?
Yeah.
Is included, yes. So that may be one of the reasons. It's
Right.
4A and 4B. The previous speaker just split it up. It's much better to look at this because you can make some absolute, size.
Maybe higher,
Sorry?
or B may be higher.
4B.
Maybe,
Yeah, yeah.
maybe. I think it is. I think multips, fine, 5%, 6%, double it, 10%. It still comes nowhere near there. They have to be pre-labour cesarean sections.
But what implications come for such bunch of numbers?
Sorry?
What are the indications for that higher number pre-labor cesarean?
Yeah, there are only two possibilities in my view. There's very little preeclampsia. Generally speaking, there's less IUGR than nullips, whatever.
Maybe,
Maternal request or previous sections wrongly in there.
yeah, that may be the reason.
Yeah.
Maybe not including the 5A.
Yes, because this size is a little bit smaller than you would expect with a section rate of 38%. Now, I'm not saying I'm right or wrong, but I'm just showing how I'm thinking. Okay?
I think you have that 4 divided into A and B.
Yeah, maybe later.
Yeah. Now, the only other thing is, I'm very surprised that the breaches are a little bit lower. They've got a high proportion of nullets, but look here. They've got a very low proxy for preterm delivery. So this is, not only is this appropriate, it's probably appropriate because of the low preterm delivery rate. So they probably transfer all their deliveries out, and it can affect, or a lot of their preterm deliveries out. Is that right?
Yeah, maybe some. I don't know. But
Well, that's low anyway.
yeah.
This is fine, but the ratio of breaches still remains. There's more breaches in nullips than in multips, okay? And this is very low as well. This suggests, not very low, but it's low. So this suggests there's a good number of deliveries here, 6,000. So this is a low-risk unit, I think, and they
Yeah.
transfer some of their multiple pregnancies out and their preterm deliveries out. Do they?
possible.
Do you?
Yeah. No.
No?
Maybe.
Maybe.
Maybe we are having very low risk group actually.
That's what I'm
Yeah.
saying.
Yeah.
So
It's
that's,
correct.
it shows in that.
Yeah. This is
Okay.
the one with diabetes. Actually, we classified into the groups, but there is no statistically significant difference in either groups for the cesarean section rate, each group.
So you classified all the diabetic patients by the 10 groups?
Yeah.
All right. How many did you have?
There were 46.
46. Okay, yeah. It probably, the numbers are so small that,
small,
yeah.
This is the induction rates. Group 1, spontaneous onset. Group 2, induce. So the cesarean section rate, so I think maybe the induction rate is very high.
It's certainly, well, no, it's high, but you're looking at it in the right way. I'll be talking about induction tomorrow, but it's always higher in nullips than multips.
Yeah.
That's the point I'd make.
Yeah. These are the indications, the fetal reasons, and the past section are the highest numbers.
So that's overall.
Yeah.
And it includes pre-labor and it includes after spontaneous or induced
Yes.
labor. And it has a lot of fetal indications and it's separately. And, you know, so I would make the argument that if you can reorganize that into a way, it would be
Yes,
more
yes. Yeah. So this is what the conclusion, induction of labor was found to increase the risk of cesarean, and since according to even with this small number, we found that diabetes has not significantly influence on the cesarean section rate. Actually the sample size is too low to carry out. That's all. Thank you.
Thank you. Is there any other data? Oh, you know, you are. Thank you.
Okay. Actually, I'm representing a kind of a secondary care hospital. I'm representing Ketumati Hospital for Women. It's a base hospital in Panadura. So, we have about 2,600 deliveries per annum. And so, during this exercise, actually, we had a bit of a concerns about as you earlier mentioned, the diagnosis of labor. Therefore, we had a bit of a struggle about to put some data. Actually, we couldn't put into the boxes out of your 10 classification. But we tried to maintain more uniformity about our inductions and frequency of vaginal examination, oxytocin, analgesics, and the fetal monitoring according to the Sri Lankan guidelines. So after this, while we were doing this exercise, we actually found this classification system actually helped us to kind of audit our all perinatal events, and actually it will give a kind of a very uniform platform where we can actually compare even institution or even inter units, even in one hospital. So we actually found out it's one of the very useful tool for our future auditing purposes. So this is actually the data we actually got after about, it's actually not a prospective study. We did a retrospective study. In Sri Lanka, we use always paper-based charts. Therefore, we had to go through about 893 charts. And out of this, we had 303 cesarean sections, and it came about 33.893. That's the average cesarean section rates for the last 5 months. So out of that, so actually we couldn't actually do a kind of a subgroup analysis like group 2, group 4, and group 5. So we took it as just one group, and the contributor for the cesarean section was the group 5 with a previous cesarean scar. And its absolute contribution was like 23.63 out of 33%. And the second most contributor was the actually nullips term, singleton nullips at term. So it contributed somewhere around 5.37% for the overall cesarean section rate. But we couldn't actually gather, or we couldn't actually extract whether our induction rate, because we didn't categorize the group 2 and group 4 into the subcategories.
Yeah, that doesn't matter. I think that's good. Can I comment?
Yeah, sure.
Yeah. These were all consecutive deliveries, were they?
Yes.
Yeah. Okay. Well, this is very interesting. So 893. It's a good number. Okay. So we should add these up, but I presume they add up. Do you see the ratio here? 6 to 30. And it doesn't matter. There's obviously a definition and a data issue and a clinical data issue. I don't think that the ratio is actually 1 to whatever it is, 5 or whatever it is. So I think my reaction to that is, this isn't just about practice or partly practice, but this is a definition of spontaneous labor and what the diagnosis is. And I would suggest that this unit probably has a definition of 5 or even 6 centimeters. And I would suggest that so that it's quite clear, and that the others, if they don't reach 4 or 5 centimeters, they put it down as an induction, which if you have a definition of 5 centimeters, so be it. So in actual fact, this is where the processes, or the list of the processes, and you alluded to them early on, would be very interesting to look at. It's 36% size, so it's probably a 40% nulliparous population, probably within the realms of average. But interestingly here, the same ratio exists for multiples as well. So if I was kind of looking at that and then going on with the discussions, we would be like we started yesterday maybe, those discussions about the diagnosis of labor. And this shows very clearly to me that you probably define it as an induction if you AR-reb them. So a lot of places have a definition of 5 centimeters, and the labor care guide is going towards that. My question is, if you have that as a definition, but it never gets to 5 centimeters, but it's 3 centimeters, 4 centimeters, and 24 hours later, the carers feel they have to do something, when you rupture the membranes then, treating them humanely, really, because they've been getting pains for 24 hours, what you record it as. And in this institution, I think you record it as an induction. So my then question is, if you're interested in cesarean section rate, because there's a big contribution to section rates, is why don't you diagnose labor the day before and help them earlier? The mother is in hospital for less time. I don't think it will affect the section rate, or certainly won't increase it because it's high already, but it may even bring it down, because these section rates are high, but they're especially high because they're only the most normal of populations. These are coming in, was it 4 centimeters, the diagnosis of labor? Do you understand what I mean? This is a small, most normal of normal patients that are coming in, and still there's a very high cesarean section rate. Am I making myself clear? So this section rate should be almost 0, because they've come in at 4 or 5 centimeters and should do very better. So these are high anyway, but in interpreted in related to that ratio, they're very high. And that section rate there in induced labor is lower than spontaneous labor. And the same here. How do we explain that? Usually it's the other way around. This is, as far as I'm concerned, not relevant, that's fine. Group 6 and 7, yeah, 100%, that's fine. The incidence of breaches is pretty low, considering you've got quite a reasonable bit of preterm deliveries. Why is that? Why is the breaches low?
One thing would be a kind of sampling error. I'm not sure whether we have missed some of the breaches, because all the digits came as the same 4.
This is kind of, this is probably a data issue. I think you're missing some breaches. Sorry? What? Yeah. Less than 1%, and you go immediately to that, and you see that, you've still got a high preterm, so it should be 2% or more.
Why is it so high, 27%?
Yes. And in a hospital before, they're coming for elective section, nobody actually, I'm sorry, and this is true, I'm not saying it's you, they don't, it goes automatically as cephalic. You have to kind of, on the electronic system or whatever you click, you actually have to put breach. It's an elective section. Why does it matter what it is? But it will come out with that. I agree with you. But you're learning to see that if it's low in one group, look for another group to see where there's a bulge. And you're right. I think you'll find some breaches in there.
Yeah.
Because this, I mean, is usually about half. It's, So data quality here, but if you use that other thing, you'll... Great, okay. We better finish now, but thank you very much. Yeah, sorry.
Single slide, but the study that was very long, 2010.
Yeah, yeah. All right, okay, great. So you should be getting very good at it yourselves now. So we look at the number of women. You always need the total number of women at the top and the cesarean section rate.
The average cesarean section rate was 22.4.
Okay,
Total number of patients were 822. This is a 3-month study.
okay, perfect. So you can see the sizes of the group, always look at that. So that's 36, probably very average, and this is 37, that's fine. There's a ratio that probably is coming down to equal, so it's 1.3 to 1, if you like. This ratio is again higher than the 1 to 2, which fits. 15%, what was the section rate overall?
Overall section rate was 22.4.
Yeah, okay. Well, you've got a very large number of previous sections, more high than we would expect. And probably, again, similar to the last one, you've got 2.1% breaches, but with a 5.3% preterm delivery rate and that size of nullips, I would expect more breaches. Not so stark as the last group, and I think they're in there. So if it's a breach in a previous section, which group would you go put it in?
I think previous section.
No, it goes
Should
into
be
breach.
cephalic.
It should be in breach. And that may be the answer for the other one. Breach overrides everything because, and the reason for that, it's so consistent in a population, it's useful to validate. So that explains that. And 1.58 twins is maybe a little bit less, but roughly the same. And your size here, 0.2%, 100 bed. This is data quality again. You see, it's always 0.2 to 0.4% and 100% section rate. Yeah, that's fine, yeah. And here, 47% in preterm deliveries, single cephalic. That suggests kind of, you've got a bit of pathology there. You've got a preeclampsia and IUGR and bleeding, because this suggests pre-labor cesarean sections.
Yeah, most of them, because these are the tertiary care hospitals.
Yeah, well, there you go, you see.
Yeah.
So it's not spontaneous labor.
Yeah.
So preterm delivery may be because of high spontaneous preterm labor, or it may be bleeding or small babies or whatever. If you've got a 50% section rate, that suggests pre-labor, IUGR, pathology. If it's preterm spontaneous labor, you'd expect a lot lower section rate because you can't stop them. Our problem is stopping them, and they just fall out, unless people automatically section a single cephalic and labor. Okay, I think we're going to be thrown out. Thanks very much. And thank you for listening. I hope you found it interesting. And well done. It's been 3.5 hours, 4 hours. So great. Thank you so much.